Hello, my name is Dr. George Ntoumenopoulos and I'm based at St Vincent's Hospital in Sydney, Australia. Together with my colleague Dr. Patman from Notre Dame University, Australia, we undertook this study entitled The International Survey of Cardiopulmonary Physical Therapy Management of Adult Intensive Care Unit Patients and the Impact of COVID-19, which is now published in the Cardiopulmonary Physical Therapy Journal. So why did we undertake this study? The practice of cardiopulmonary physical therapy does vary internationally. The evidence base for the use of cardiopulmonary physical therapy within the ICU does support its use to assist with secretion clearance and lung recruitment. However, there is limited evidence to support its impact on major patient outcomes. The COVID-19 pandemic also, we suspect, may have impacted on the cardiopulmonary physical therapy service delivery within the ICU. Therefore, we wanted to report on the cardiopulmonary physical therapy services, including the outcome measures used, the interventions utilised, and the staffing profiles for patients within the intensive care, both with and without COVID-19. We utilised an anonymous online cross-sectional survey with a total of 46 questions, which included the evaluation and assessment tools used, the interventions used by physical therapists within the ICU, both with and without COVID-19. We also obtained details on hospital bed numbers, ICU bed numbers, and the physiotherapy staffing profiles. The participants studied included English-speaking physical therapists from adult ICUs across Europe, North and South America, Australia, Asia, Oceania, Sub-Saharan Africa, and New Zealand. Now for the main results. There were 309 respondents. Most of them were female, aged 31 to 40 years, and most had only worked for up to 5 years within the ICU, and most were working full-time. Most worked within public hospitals, within mixed medical and surgical ICUs, with a bed range of around 11 to 20 beds. And most of the respondents were from the United Kingdom, followed by Europe, then Oceania and Australia. The physiotherapists reported on average seeing 7 to 10 patients per normal work shift, and 41% of them, importantly, reported having an after-hours physiotherapy service. However, only 69% reported being autonomous professionals, therefore not requiring a medical referral for the delivery of physical therapy. Now, the main indications for cardiopulmonary physical therapy beyond airway suctioning included the presence of acute lobar atelectasis or collapse on the chest X-ray, the presence of audible secretions, reduced or added breath sounds on auscultation, reduced arterial oxygenation, increased patient work of breathing, and the presence of an ineffective cough. The most commonly used outcome measures included transcutaneous arterial oxygenation, lung auscultation, the assessment of cough strength, and the assessment of chest wall movement and patient observation. For patients without COVID-19, the most commonly used interventions included patient mobilization, patient repositioning to optimize gas exchange, airway suctioning, deep breathing exercises, active cycle of breathing techniques, weaning from mechanical ventilation, oropharyngeal suctioning, and postural drainage. For the COVID-19 cohort, there was a similar use of patient repositioning to optimize gas exchange and postural drainage for circulation clearance compared with the non-COVID-19 cohort, and adjustments of mechanical ventilation and weaning for mechanical ventilation. But there were lower rates of use of other interventions such as patient mobilization and endotracheal suctioning. So in conclusion then, this international survey reported that the outcome measures used and the interventions delivered within the intensive care unit predominantly align with the published minimum standards for physical therapists working within the intensive care, mainly across the United Kingdom, Europe, and Australia and Oceania. There were some differences in the physical therapy delivery of interventions used in the COVID-19 cohort. For example, less patient mobilization, and this may reflect the requirements for deeper sedation practices, and also some disease-specific problems such as mucus plugging with the relatively frequent use of postural drainage within this cohort. Thank you.